Welcome everybody to Working in the Lyme and Tick-borne Disease space with our special guest, Dr. Kenneth Liegner and Family Nurse Practitioner, Erica Glazer. Tonight's guest, Dr. Liegner, is a board-certified internist with additional training in pathology and critical care medicine, and he practices in Pawling, New York. He's been actively involved in diagnosis and treatment of Lyme disease and related disorders since 1988. He's had numerous published articles in peer-reviewed scientific journals, and he's presented poster abstracts and talks at national and international conferences on Lyme disease and tick-borne illness. Erica Glazer is a board-certified family nurse practitioner who's had over 23 years of nurse practitioner experience. She joined Dr. Liegner in 2008, caring for patients with Lyme disease and related disorders. She's passionate about providing care to this patient population, and she understands how we're often marginalized by mainstream medical providers. So welcome to you both. After a bit of technical difficulties, we're able to start our conversation. And so happy to see you. Dr. Liegner, I haven't seen you since 2014.
Yeah, well, first of all, I want to thank you for inviting us to participate in this. And I guess it is Lyme Disease Awareness Month, right? May?
Absolutely.
And I was just saying that we originally met, I guess for the first and only time so far, when you had a seminar up at a bookstore in Holyoke, right?
That's correct.
And that, boy, Tempus fugit, right? Time flies. But anyway.
In a pandemic in between.
Yes, a heck of a pandemic. So anyway, thanks so much for inviting me and Erica to share some time with you all.
Thank you so much for making space for us. So tonight, we've had several pre-questions about your work. And I guess generally people want to know, what is your approach to Lyme disease and tick-borne illness? And when a new patient comes to you, what are some of the things you're looking for from the patient?
Well, I got into Lyme just by pure chance. It's not like I went looking for it. I opened my practice in Armonk in about 1985 or 86, and knowing almost nothing about Lyme except the name. And but I didn't realize at the time, I guess a lot of people didn't, that at that point in time, Westchester was at the beginning of a burgeoning epidemic of Lyme disease. And I started a new practice, and like any internist, you couldn't help but see some patients with Lyme. And then, I found that they really didn't behave the way they were supposed to, like supposed to be treated and done, right? But their symptoms kept coming back. And then because I was interested in our local library, which was in Armonk at the time, the librarian had approached me about trying to arrange a series of medical talks. So I arranged talks, a bunch of different topics with different people. And then I chose for myself the topic of Lyme disease. And this is around 1988. And we had a nice medical library at Northern Westchester Hospital Center, and a very nice and cooperative librarian. And basically went through as much as I could. And at that time in 1988, you could spend 3 months and have gone through pretty much what was available. It was possible. Of course, now the literature is so vast, it's almost oceanic. It's really hard to keep up. But anyway, so I spent a couple of months, boning up on Lyme disease, and I gave this talk, and there was a lot of interest at the time because a lot of people were getting sick. And it was in the basement of this the old library. They since have renovated it. It's a grand library now, but it was a tiny little library, tiny little basement, the linoleum floor, and like 300 people showed up in the basement, So I gave this talk, and all of a sudden I was a Lyme expert. But I knew I wasn't the expert. But the only thing is, I knew more than anybody else of the other physicians, because I spent several months really studying it. And then, but anyway, I mean, it's been a real learning curve. I mean, it's very challenging. It's challenging for the best of us. You're always learning. All of your preconceptions are being challenged all the time. And the first thing is, like any good practitioner, you have to take a careful, thoughtful history, and that should be informed, of course, by what you know or what you think you know about tick-borne illnesses. You have to ask the right questions, and then depending on what the patient answers, that will then stimulate other questions. So it's kind of a call and response kind of a thing, and so then you have a tentative diagnosis, you have a differential diagnosis, and if you think it's in the Lyme or tick-borne diseases, area, then you're going to discuss different options for treatment, because there are a lot of different options. And when I first started out, pretty much all we thought of or knew about really was Lyme disease. So we thought everything was Lyme disease, and it turned out, whoops, everything isn't Lyme disease, right? Joe Burrascano, who a lot of you probably know, I mean, he started out, even before I did, and he was always suspecting that there were other things. I think he was one of the first people to suspect, or to point to the possibility of babesiosis. Of course, he was out on East End of Long Island, and also very early on, he raised the possibility of Bartonella, and of course, both of those have turned out to be very important. And so again, careful history, careful physical, formulating tentative diagnoses, and then trying to decide with the patient among the different ways to treat, select which way that you treat. Now Erica joined me 2008, and Erica was she reserved judgment on all this. She was kind of, you were dubious about a lot of this, right?
It took me, I would say, probably a year working alongside Dr. Liegner to really fully wrap my head around what I was seeing, having known nothing prior to meeting him, except what I had learned in school, which was, the old dogma. It's easily diagnosed and easily treated. And if anybody has symptoms beyond that, there's something else going on. And so it took me quite a while to fully immerse myself and believe what I was seeing. And of course, Dr. Liegner, being as credible as a person as he is, helped, but also there was a lot of research that he gave to me to read, supporting what we were doing and what we were seeing. But I would also say, in terms of, approach, it's very difficult to answer that question, because each patient is unique and there is no one size fits all approach. It really takes some time working together with the patient to figure out exactly what's going on, what the best treatment is, and how to get that patient to the best possible place clinically. It takes time to figure that out. So it's difficult to answer that question, what's your approach, because we don't have a one size fits all.
I think one thing is that we agree is careful study of the patient over time, their response to application of treatment, also what happens if you suspend treatment, because sometimes it's prudent to suspend and observe, and how they respond to different different treatment interventions. And also I sometimes say that I'm a little bit plodding, 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 methodical. I prefer to try to introduce things one at a time, aiming at maybe the most important thing first, and not throw too much intervention at once, because it gets too confusing. You have too many variables.
Mhm.
And then if the patient does respond, you don't know what they're responding to. And if they have an adverse reaction, you don't know what's causing the adverse reaction. So I tend to be a little bit more long and drawn out, and kind of we stage things a little bit more rather than just, I mean, there might be some situations where you have to throw everything but the kitchen sink right at once.
I would
But
just,
yeah, but
depending on the case.
it all depends on the patient. But in generally, if it's not a, critically ill patient, I tend to be a little, approach things cautiously and introduce things carefully. And, the goal is not to make patients hercs, so-called hercs. That's not the goal. The goal is to get them well. And sometimes by being overly zealous in the treatment, you just make the patient miserable. And it's not necessary to do that.
And have you found that there are more and more patients that are very sensitive to the medications and the protocols that you use? That your approach, your cautious approach, is maybe a safer one for these patients?
I think so. I mean, it's hard for me to compare because some people handle things very well and some people are very sensitive. It really varies a lot. But as a general rule, I mean, there are situations where you have to intervene vigorously for depending on the circumstances. But there's lots of situations where a much more graded, gradual approach is better tolerated and actually appreciated by the patients, rather than hitting them very, very hard.
People have also been asking about what are some of the newer protocols that have been put in use in, say, the past 5 years.
Well, there's a whole range of antibiotics, oral or parenteral, either intravenous or intramuscular. And then there's the antiparasitics aimed at babesiosis. So I mean, some of the newer things, which I'm sure many of your viewers are aware of, some people have been applying, for example, methylene blue aimed at Bartonella. I know, Rich Horowitz has been promoting the use of dapsone in various combinations. Very recently, folks out of Yale have, well, it wasn't just out of Yale, but tefenequine, which is a quinine-related agent, has been shown to have a lot of potency against babesiosis, maybe more potent than the things that have been traditional. And Chukri Ben Mamoun, who's out of Yale, has been doing just fantastic research. If you're not familiar with his work, you ought to check him out on YouTube. And he just recently published an article on what he called a radical cure using tefenequine, I think, azithromycin, and atovaquone in a mouse model, in which he was able to, I guess, sterilize the mice of babesia. But still, a man or a woman is not a mouse, so I'm not convinced that it's necessarily the magical cure, but it certainly seems more potent than Zithron and Mepron, for example, or Malarone. But and then of course disulfiram, yeah, which we published on in around 2019, which is very, very potent, but has to be used with a lot of care because it can have potential toxicities. But it's still it's very potent. So.
And Erica, how have you changed since 2008 in your approach to helping Lyme patients and tick-borne illness patients?
Well, how have I changed? I definitely like to use some alternative treatments. I know patients are asking about it, and our patients are very well informed as to, alternative and integrative treatments. And traditionally, our practice is not an alternative integrative practice, but I do feel that there is a role for some alternative and integrative treatments. So I try to incorporate you know, in treatments that are researched and, you know, that I'm comfortable with, to help patients to get to a better place. So I'm trying to sort of branch into that a little bit, but our practice traditionally has not gone down the alternative route, only because it's kind of out of our scope of practice. It's, you know, the naturopaths or integrative providers are very knowledgeable in that area, more so than we are, but we're branching into it, you know, a little bit.
So that's not really my training. You know, my training is, make a joke, I'm a shameless allopath, you know, but that's my training. And but I don't have anything against those integrative approaches. But my feeling is if somebody wants to avail themselves of that, what I usually do would be to suggest they work with a naturopath who has that specific training, and I'm fine working in a collaborative way, and that hasn't been a conflict at all. And I've said many times that I believe many paths to wellness. You know, besides what I do, hopefully I can help people, but there's lots of different ways to get well.
Yes,
And
I might start them off on some treatments, but if it gets to a point where, you know, my comfort level is just not there, then I help them find somebody also who can sort of pick up that piece of it.
the team approach is so important, and it's wonderful how I've seen you working and talking with the other medical professionals in the field, with ILADS and other conferences. It's great to have someone who's vested in allopathic medicine open to these other methods.
There's some patients that their cases are pretty straightforward, and you know, one practitioner can kind of take care of everything. But a lot of these patients, they're really complex, and it's essential to be working with people who have expertise in other disciplines, and then to communicate with them. You know, just picking up the telephone, like it's amazing how rarely that happens these days. But yeah, so to try to develop over, you know, years or even decades, collaborators who are like-minded, who cooperate well, is that's very helpful for any consultant, you know, to have. So and you often really do need a team approach. Like one person can't do it all for a lot of these cases because they're just too complicated.
Dr. Liegner, I just wanted to jump in real quick. We have a couple of questions in the chat. They hadn't caught the name of the doctor that the name of the doctor that you referenced out of Harvard, who had published research that you referenced.
He's out of Yale.
Out of Yale. Okay.
That's Choukri, Choukri. That's his first name. Ben Mamoun, Ben. The last part of his name is Mamoun, M as in Mary, M as in Mary, O-U-N. If you go to PubMed and put in his name, you'll see just amazing contributions. You know, such detailed work. He's been able to culture Babesia duncani in vitro, I think, in a blood model. You know, that's very challenging. Like a lot of these Babesia, you have to maintain them in an animal model. You know, like and that gets costly. You know, and difficult. So to be able to develop a means of culturing B. duncani in vitro is really, really important. I think microtia, I think they still can't do that. They have to do that in an animal model to keep the cultures going, you know. So yeah, and he's a very fine scientist, very open-minded, very collaborative, very nice gentleman to deal with. And by the way, he instituted something called the IBMs. No, not ICBMs and not IBM like International Business Machine. It's the International Babesiosis Meetings. There's been 1, 2, 3. There've been, I think there might have been 4, maybe 4 is coming up. But he usually puts notice out, and you know, if people are free to join. And I've gone to a couple of them. They're very interesting. Some of them are they're very, very technical, way above my pay grade, as they say, but doing really great work. I encourage people to check out his work.
Wonderful. Thank you so much. I'll turn it back to you, Maria, for more questions.
Thank you, Nellie. Babesia, it's a big topic with our clients. And how do I know how it's gone? How is it eradicated? Is there a test? And that we also have that same question about Lyme disease as well. So there's two tough questions for you.
Well, the so-called 3 big Bs, Borrelia, Bartonella, and Babesia. I mean, each of them is really challenging, and it's difficult to ascertain when you've done treating whether or not the patient is cured or the infection is eradicated. And whereas, Lyme is really, it's still unbelievably, it still seems controversial that there's such a thing as chronic Lyme. I mean, you can't even utter the words chronic Lyme disease in academia or in government. I'm not joking. You can say post-treatment Lyme disease syndrome, but you can't say chronic Lyme disease. But oddly, the mainstream has embraced that babesiosis can be chronic. Even the mainstream accepts that. And you know who Gary Wormser is, right? He was the lead author of the Infectious Diseases Lyme Disease Guidelines of 2000 and 2006, in which he declaratively states there's no such thing as chronic Lyme, impossible, no such a thing. But he was one of the authors on this case of relapsing babesiosis that they applied to tefenoquine. Of course, that group asserted that this gentleman who was immunocompromised, that with one application of a tefenoquine, they followed him for a year, and they were not able to detect the organism, and so they declared him cured. So I don't know whether it's a cure or not, but in other words, what I'm getting at, he still can't acknowledge that Lyme can be chronic, but babesiosis can be chronic, but Lyme can't be.
To answer that question, there is no test that tells us when the infections are cleared. And it really goes back to, again, close study of the patient over time. And patients ask me that question all the time. So the typical guideline that I'll try to use with them is to stay on their treatment for 2 to 3 months past symptom resolution. And then we come off and we see what happens, and we watch, close study of the patient over time. But sometimes it's hard to even get to that point, symptom resolution. Many patients don't get that. So it's really working closely with each individual patient, and we work together. It's not just me telling the patient what to do. The patient plays a role in working with me to figure out what's the best course of action for that particular patient. How well are they? Is it a good time to stop treatment and assess and see how they do? Are they stable enough to do that? And so these are some of the discussions that we'll have at visits when a patient is ready to come off or wants to come off their treatment.
We see a lot of clients that they're dealing with grief from their chronic illness. And do you have suggestions for those people who are grieving their health and looking at the future as, will I be living like this forever? How is this going to affect my life? And being very depressed about the situation and being gaslit by other practitioners.
Yeah, I imagine a lot of people have seen that recent article by Jen Fagan and Jenna Luche-Thayer about medical gaslighting for Lyme. Have you seen that paper?
Yes, I have.
Yeah, it's an excellent paper. So it's definitely a very real, and that it's bad enough to be dealing with these difficult situations, and then to be dismissed and disbelieved and ridiculed, it just adds to it. And that can certainly, add to a sense of despair that nobody's really trying to help the person to get better and feel better. And you know, it is a lot to come to grips with, chronicity. Obviously, not everybody pursues a chronic course. Some people are able to be treated. They get a straight, either a simple course or even a prolonged course. They get to a certain point where they're feeling well, they stop, and they seem to remain well. Are they cured? Microbiologically cured? It's hard to say. I don't really know. I don't even use that word, because how can you determine? Either they can stay well off of treatment or not, and then if they relapse, then you have to reassess them. And fortunately, we have. I mean, I'm very appreciative of IGNX and its methods, because like their fish method, their BZ fish method is very, very useful. So if you have a positive fish, some reasonable time after completion of treatment, unless they've been reinfected, which of course is always a possibility. If you live in a tick infested area, you have to really go out of your way to avoid new tick attachments. But if you haven't had a new tick attachment and you have relapse of symptoms, you're able to detect positive Babesia fish or a PCR, then it helps you to know that that likely it's relapsing, and then you have to deal with that. So it is demoralizing if you relapse. I mean, it's people don't want to be sick. They want to be well. They want to pursue a normal life and pursue their goals.
I would say it depends again on the case. I do spend a lot of time reminding my patients where they came from and how far they've come, because progress tends to be slow and they forget because they're still sick. I mean, we could be working together for a year and they've made incredible progress, but they're still sick in so many ways, and we're still working to improve their health. And so they forget what they were like when they first came in. So I do spend a lot of time reminding them how far they've come, and just trying to give them hope that if we've come this far, we can get you, further ahead. And usually that is the case. It can be very slow for some patients. And then there are patients that really do need some help in terms of, therapy. And I would say not traditional therapy where you would go and you would have weekly visits. I think that's almost too much, because these patients are feeling grief and despair because they're sick, not for other reasons where they need to, revisit their childhood wounds or, things where you would have to go on a weekly basis. And so there are some Lyme literate therapists. I mean, Sandy Berenbaum comes to mind. I don't know, is she still practicing? I think she is.
I think so.
Yeah, where it's a little more relaxed, there's weekly visits for patients who are sick. Sometimes they don't know how they're going to feel when a visit comes up, if they can even have that visit to sit and discuss with a therapist how they're feeling. So there needs to be somebody who has that understanding of the chronicity, and how a patient could feel fine 1 minute and the next minute they're in bed and can't move, kind of thing. So they wouldn't be able to have a visit. So there needs to be the latitude to, have flexibility with visits and an understanding of just dealing with a chronic illness.
And this,
And sometimes,
oh, I'm sorry, this leads me to another question that's connected to this. Do you do virtual visits?
no. You mean like Zoom consultations? We don't do that in this practice. We always, when we establish a patient, that they must be seen in person in the office. We'll often work with them by telephone, and because we see people from all over the place. And we used to kind of more or less insist that they come in and be seen at least annually. Of course, the pandemic threw a monkey wrench into that, so it's a little bit more relaxed than that. But guess what? It's important to examine your patients. Yeah. You'll learn things that you wouldn't know otherwise unless you examine them. But we do work by telephone, and I've been very reluctant to get into the Zoom consultations. You get all kinds of regulations and HIPAA and all this stuff, and where thank goodness we're not HIPAA. We're outside of HIPAA. I don't know what I would do if I was in HIPAA. It's impossible. So, and I think if you, maybe I'm wrong, but it's my impression that you start doing Zoom, you have all these HIPAA regulations, and so the answer is sorry, no. I mean, people do have approached us and would like to do that, and some of my colleagues do that, and I guess whatever they're comfortable in doing it, but yeah, sorry, we don't do that.
I'm just looking at the list to see if there's any new questions. And please, in the audience, feel free to type your questions in. Nellie will moderate and make sure that they get answered. So patient comes into your office, complex chronic illness. What would you like to see in your perfect patient for bringing information to you before the appointment? What kind of workup, what kind of testing would you like them to have prior to the appointment?
Well, we always encourage the patients to bring a complete set of records, pertinent records that have been developed in their case by other practitioners that we can keep, and also they should keep a set for themselves. But we don't. I mean, we could tell you what the typical laboratory evaluation is of patients who we have seen, but it's kind of odd. We don't necessarily encourage people to have the workup before they come to us, because then we have a doctor-patient relationship, and we've never seen them. That's kind of awkward, But I mean, we do in terms of general labs, we do a pretty broad-ranging bunch of labs to try to assess and make sure that we're not dealing with some other entity, like some primary autoimmune condition or some other illness, like, for example, sarcoidosis, which can there's a lot of overlap, can be a lot of overlap between sarcoidosis and Lyme disease. So we do fairly extensive testing that's available from a general lab, like Quest, LabCorp, and looking for inflammatory markers. We always like to see if the patients happen to carry HLA B27 alleles, or the HLA DR3 or DR4, which is more associated with autoimmune or immune mediated arthritides, and we also rule out some of the other diseases that can be confused. It's important to rule out syphilis, for example. And then as far as tick-borne diseases per se, we do as extensive testing as we can do that's feasible for the patient through IGeneX. They have a wide range of things. We're kind of very frustrated in New York because the New York State Department of Health, for reasons known to them, has not approved certain tests that we would like to do, but we can't do, and also there's certain labs that I'd like to use that the Department of Health does not permit a New York State physician to use. I can't use Galaxy Diagnostics, which is ridiculous. It's one of the best labs in the world for Bartonellosis. I can't use them. And there's some other labs. For Babesia duncani, we use County Sonoma Public Health Department, because they're a state public health department. I don't think even New York State would prohibit me from using a state public health department or county public health departments. So I can't do Babesia duncani through IGeneX, but I can do it through the public health lab in Sonoma, And it's surprising how often we get positive results on duncani, which is theoretically shouldn't happen, because the ecology that supports duncani is pretty specific for the West, and we don't have that ecology, either the ticks or the cervids. And I don't know if many of you know John Scott and the wonderful work that he's done up in Canada, but
No.
check him out on PubMed. John Scott. amazing article. He's an independent researcher, but he's collaborated with first rank academicians and published like amazing papers. So he's the one who first not only raised the possibility, but actually demonstrated that some people who were sick with Babesia-like symptoms, they don't have microti, they don't have Duncani, they have this otocolia, right? And furthermore, he has asserted that antibodies for otocolia cross-react with Duncani. So a lot of those Duncani patients that we're seeing, you know, who've never been west of the Hudson, much less west of the Mississippi, they may have otocolia, you know, which is very common in the deer. So why wouldn't it be common in the ticks? You know. So anyway, and then John is a real pioneer. So like any pioneer, he's gotten his share of hard knocks from people who are skeptical. But I suspect that he will be, you know, fully vindicated, you know, in the long haul. But there's a lot of people who are dubious about otocolia, but it makes a lot of sense.
Thank you. I'm just looking in the text. Someone has a more specific question that we've already answered, talking about protocols. And I want to remind the audience, we can't give specific medical advice in this format. You'd have to make an appointment with Erica or Dr. Liegner in order to get that level of information. And please, if you came in late, do watch the recording of this series. It will be on our YouTube page. Sorry for that pause. So getting...
I wanted to just add to the laboratory question.
Okay.
Many of our patients, by the time they get to our practice, they do come in with records that could be dating back 10, 15, even 20 years. So most of the patients that come here have had quite thorough workups before they get here. But we still also do our own workup to, you know, make sure we're not missing things and try to identify, you know, what tick-borne illnesses are at play. But having said that, you know, these are clinical diagnoses. And so it's important to stress to the patients that if your tests are negative, that does not rule it out. You can still have these infections. And that's why it's really important to take a thorough history and figure out exactly what is going on with the patient, because you can often identify what infections are at play just from the symptoms that the patient is reporting.
That's helpful. And I'm sorry, I'm pausing to look at the text again. Let's see. Whoop, I'm sorry. Sorry for the pause. One of the other questions people are asking, we have people from all over the country coming to us now. We used to be a hyper-local organization to the Pioneer Valley in Massachusetts. I have clients asking, out in the Midwest, out in Texas, out in California, are there options for other medical practitioners, or could they travel and come to see you?
Well, if you check out through the Lyme Disease Association, through your organization, through the Global Lyme Alliance, maybe through LymeDisease.org, a lot of them have lists of practitioners who are well informed in many different areas of the country. Also, there's the Texas Lyme Alliance, you know, with Christina Pedersen Bauer rather. You know, there at this point there are a lot of practitioners in different areas of the country. Of course, if people would like to see us, they're welcome to call and find out the office policies and procedures and see whether they would want to do that. One other thing I want to mention, the cost of treatment can be significant. And one thing that we try to do here as much as can is to try to be considerate about the cost of treatment. For example, I'm probably the most intensive user of amoxicillin that I know of, even among people who are in ILADs. Amoxicillin is still an excellent drug for Lyme disease, and it's inexpensive, and it's safe, and contrary to popular belief, if you use an appropriate dose, which has to be a fairly high dose, it also crosses the blood-brain barrier. So I'm a big fan of amoxicillin, for selected patients, and it's inexpensive. Another thing, we certainly done our share of intravenous antibiotic therapy in my practice, but in recent years we've done a lot more. If somebody needs ceftriaxone, we found that a lot of patients can tolerate and deal quite well with intramuscular ceftriaxone, and with proper instruction. And when Rocephin first came out in the 90s, it was like $90 for a 2-gram vial. Well, now it's under $10, maybe under $5 for a vial. And so you get some ceftriaxone, you get some lidocaine, you get some needles and syringes. This also has to be prescribed by a physician or a licensed practitioner. But and then we'll often not everybody needs that, but if they do need it, we often will have the patient come in, get an observed initial dose IV, and if that goes well, and the reason for giving it IV is if they have an allergic reaction, you can shut off the IV and stop it right away. Because once you give something IM, it's in your system. But I'm just saying that turned out to be very, very practical and inexpensive. I mean, relatively speaking. And many of the patients, either their significant other or even themselves, as some patients have the mental fortitude with proper instruction and support to self-administer that. So and so we've done a lot less IV antibiotic therapy. And then of course disulfiram, although it's tricky, it's very, very potent, and it's inexpensive, so it's another option.
We just had a question come up about biofilms. Is it necessary to remove the biofilms for the antibiotics to be effective?
Well, Eva Shoppe in her papers has stated, and others as well, that the presence of microorganisms within biofilm makes them 1,000-fold resistant to the action of antibiotics. So yeah, if you can get rid of biofilm, that's good. But then the question is, how do you do it? And there is ongoing research about biofilms and therapy for biofilms. I don't know how many of the readers are familiar with MDPI antibiotics. It's out of China actually, but they put out excellent issues and very high quality. I think they had a special issue recently about biofilm. So there is research on it. I mean, the biofilm is actually created by the organisms themselves. So the idea is that, well, if you can get rid of the organisms, you should theoretically be able to get rid of the biofilm because it's a dynamic process. One of my hypotheses about why disulfiram might be more effective than some of the standard antibiotics is because disulfiram itself and its breakdown products are very, very small and probably very diffusible. So biofilm has a structure, and CO2 and oxygen goes in and out of the biofilm because it supports the metabolism of the organisms. So again, it's a hypothesis, it hasn't really been demonstrated, that the disulfiram may be more effective because it's able to penetrate biofilm and get the organisms where they are. Now, disulfiram is very effective against Borrelia, it seems to me, maybe somewhat against Babesia, and not much at all against Bartonella. So
now we've talked about the 3 Bs. What about some of the other co-infections that you see in your patients?
Well, we often will see people who have antibody evidence of exposure to Ehrlichia anaplasma. Once in a while, Rocky Mountain spotted fever. It hasn't been very common that we've had people who are acutely ill with Ehrlichia anaplasma, right? Although we've had some. Of course, all of those, Rocky Mountain spotted fever, Ehrlichia anaplasma, worst case basis, they can be life threatening, you know? And it's really important for them to be treated. And the treatment for them is drugs in the tetracycline family. And then, have we had anybody with Powassan?
No.
I mean, Powassan is very, very dangerous. And there have been fatal cases. I know there's been a number of fatal cases in Maine, possibly in New York.
There was a New York.
Massachusetts as well.
Yeah, and that's, readily transmissible, they say, within 15 minutes of a tick attack. So, these ticks have more things than just Lyme disease in them,
Tick attachment, another good question. People are being told by urgent care, emergency room, primary care, the tick has to be attached 24 to 48 hours. Can you explain to the audience how that is not a valid time limit?
In my opinion and my experience, and even in the literature, it's not true. There was an excellent article by Patmas, P-A-T-M-A-S, in one of the early Journal of Spirochetal and Tick-borne Diseases articles. All of those, by the way, are accessible at the ILADS website, and you don't have to be a member. If you go to the ilads.org and go to research, there's a drop-down menu where you can get to every issue of the Journal of Spirochetal and Tick-borne Disease. It's open access. And Karen Forshner of the Lyme Disease Foundation, who founded that excellent journal, but unfortunately it never quite made it onto PubMed. But she gave authorization to ILADS to put that on their website. You could probably find that article by Patmas, very well documented, of erythema migrans within 4 hours of a tick attachment. There's a lot of this dogma that it's based on incomplete study of the issue. So I mean, nobody really knows what time zero is for transmission, and it could be that a small inoculum could take a long time to develop into something that's symptomatic clinically, months maybe, or a year or more. So it's tricky.
Here's something someone asked: how do you know when a tick disease is chronic? That's a little vague, but I'll toss it into your laps.
Well, Sam Shore, who was a former president of ILADS, honchoed a very nice article on the evidence base for chronic Lyme disease. For years, the IDSA has been, there's no such definition of chronic Lyme, it's undefined, it's nonsense, So Sam and the collaborators on that paper thoroughly combed the literature. It's an excellent paper. I think somewhat of an arbitrary definition. Well, of course, if you have the illness and you're never treated, well, it's ipso facto chronic, right? It's never been treated. And people often get picked up months, years, or even decades after the onset of the infection, right? We've sometimes seen that. 20, 30 years later, we figure out, they had this actually, all these years undiagnosed. But in terms of for people who have had Lyme, been treated, and then go on to a chronic course, I think we use like a somewhat arbitrary cutoff of 6 months, after which they were deemed to be, quote, chronic. And different entities, they use different criteria. I think for COVID, some people use like 3 months maybe as a, long COVID. So it's a bit arbitrary. But basically, first of all, it's hard to know what the patients really have, or do they only have Lyme? Do they have Lyme plus A, B, C, D, or E? But basically, if you're treated, get well, and then at some time later you relapse in the absence of a new tick exposure, then I guess you're in the sort of the chronic or relapsing realm. But I guess there are different ways of defining it.
Someone has just asked about reactivated viral infections, and when you're doing your workup, if the patient is exhibiting symptoms of Epstein-Barr or herpes zoster or HHV6, are you running tests for these other viral infections as well?
Yeah, we often include, antibody panels, but those are not always so easy to interpret. If I'm thinking that the patient may have reactivated EBV, it is possible even through a commercial reference laboratory to do PCR, both qualitative and semi-quantitative for EBV. I'm not so sure about CMV or HHV6, but yeah, I mean, Lyme affects the immune system, and then acute viruses also affect and alter the immune system. And a lot of the practitioners who dealt with the COVID patients have observed that for some of the COVID patients, acquiring COVID seems to upset the balance of the immune system that had been keeping the tick-borne diseases, sort of in check. So that's also a possibility. It can go both ways.
And I've been asked, and I don't see it in the list, but I know clients have asked me, difference between tick-borne illness and long COVID, chronic Lyme long COVID. Is it hard to separate the two symptoms that come up with these two issues?
There's a lot of overlap. And we've, wisely or not, I've kind of stayed out of the COVID fray just because in New York State, I've just felt it's too dangerous for the physician to get involved, which is a sad commentary. But there's a lot of overlap of the multi-system symptoms. At Mount Sinai in New York City, David Petrino, who's a physiatrist, has a PhD, they've been studying long COVID in a systematic way, and I believe they've recently got a grant from the Cohen Foundation to concurrently also study, what do you call it, long Lyme or chronic Lyme. So that I think they're going to be studying them in parallel, probably doing, also laboratory testing. So.
And that's exciting that something so devastating as COVID has brought to light chronic Lyme. How has the research changed for chronic Lyme in the past 4 years since COVID?
Trying to think about that. Well, I think you may be aware that there was a symposium held in Washington, D.C. within the past, 6 months or so, the title of which was a chronic illness post-infections. And it wasn't just Lyme, it was Lyme, COVID, and a few other things. And it was multidisciplinary, involved the patients. It was open to viewing by anybody, which I did. I viewed pretty much the whole thing. It was very, very good. And there was no, it wasn't fraught, everybody was collaborative, open-minded, friendly. It wasn't warlike like what we sometimes have seen. By the way, it'd be good if we could get over that, if it's possible, get more collaborative.
And we try to stay neutral and focus on getting the patients the resources they need at the Lyme Center. And it's why we bring these educational events. We have so many different types of topics that it's important people know the options that are out there for treatment and recovery. And speaking of which, someone's asking about mineral-based treatment, and I know you said in the beginning that you're not very familiar with the more alternative treatments, but willing to work with the naturopaths and functional medicine doctors. This question is about Lyme N, a mineral-based treatment that's via a nebulizer. And it's a non-conventional treatment.
I'm not familiar with it. Of course, methylene blue is, in a way, is a mineral-based treatment. You know, it's a dye, and it has a lot. It's a very interesting agent, and it seems to be fairly safe with you take certain precautions, and has a lot of different properties in addition to antimicrobial properties. So, but I have to say, I'm not familiar with what the questioner is asking about.
Another question, and they say this may be an impossible question to answer. Do you have any idea of the percentage of your patients that go on to achieve remission for 10 years or longer?
We don't keep statistics. Certainly there's many patients that work with us for a period of time. At the time, it seems like the treatment is never ending, but many of them at a certain point, they get to a point where they're feeling well, and either unilaterally or desirably, you know, by consensus, you know, treatment is stopped, and a lot of them remain well. And it's hard for me to predict who that is going to be, but you know, in the past, we would often get, you know, either a patient is referred to us, and the patient who's coming to us, oh, you were referred by so-and-so, and she's so grateful that you cured her, you know, Lyme, whatever. Or we would get like an annual Christmas card from patients, you know, 10 years out, you know, who are remaining well. So, you know, again, you can't make a blanket statement. Everybody's different, and, you know, you try to do your best. And of course, the goal is to either get them into an enduring remission or cure if that's possible.
Erica, in your experience since 2008, how do you feel treatment options have changed, and what's your view for the future of Lyme treatment?
Well, as Dr. Liegner said, there are some newer treatments that he actually has more experience with than I do, although I do have experience with disulfiram. But I would say I don't see there's been much change aside from the methylene blue to phenequin, disulfiram. Horowitz he's got his protocol, right? I don't think there's been a lot of change.
One thing is that Kim Lewis from Northeastern has been developing this drug hygromycin A, and I think that's going to be going into clinical trials soon. So that's an agent that was known to exist for a long time, but it was thought that it wasn't going to be clinically, you know, useful. But it was kind of revisited and recognized that it actually has very, very high activity against spirochetes, and also it's a drug that has a very low impact on the gut microbiome. So I think that's coming down the pike. It's hard to say when that'll be clinically available. Again, I think they're going to be starting some clinical trials within the next year or so. So that's something new. However, if you think about it, there has not been the kind of commitment from the federal government in terms of funding to really support, to take it, like if you deny the problem, if you deny that there's such a thing as chronic Lyme, why would you throw gobs of money at better methods of treatment? It seems to me all the funding is going towards vaccine development. Yeah. Like vaccines for COVID, don't treat it, but to take a vaccine. Same with Lyme, don't treat it. There's no such thing as chronic Lyme, but it's serious enough that we have to get this vaccine out there, So that it seems to me that's where a lot of the federal government emphasis has been, rather than, first of all, I am extremely frustrated that there's this test that has been available since 2015, or has been developed as far back as 2015, sitting on a shelf, developed by the finest biomedical scientists in the world at NIST, the National Institute of Standards and Technology, that used HPLC, high pressure liquid chromatography, and mass spectrometry to detect the outer surface proteins shed by Borrelia. And how did they do that? Why they did that? John Aucott, with his SLICE studies, he approached people at NIST and said to them, look, our tests for Lyme are not very good. They're lousy. And the people at NIST looked at the data and they said, yeah, we agree, they're lousy. So they used their sophisticated methods to develop this. It's published, and nobody's pursuing it. It's maddening. And meanwhile, the what do you call it, the Lyme Diagnostic Prize and all that stuff, they're doing all kinds of other approaches, and it's like reinventing the wheel. This has already been developed, and it's based on the basic biology of Borrelia. Borrelia cannot help but shed these outer surface protein rich blebs. It's part of their biology. They can't help it. And you could have it both qualitative, and I believe you could have it semi-quantitative. Just like with HIV, is the viral load going up or is it going down? Is the treatment working or not? We could have that. I believe we could have had that, but nobody's supporting it. I actually approached John Aucott and said, well, how come this is sitting on a shelf? And he said to me, well, there's no funding for it. Sir, that's ridiculous.
That's crazy.
There's no will to fund it, apparently. Because then you'd have to acknowledge that chronic Lyme disease exists.
Incredible.
I can forward that to you, Maria.
Please do. And that test would cover all strains of Borrelia?
Well, you can design the outer surface proteins that you want to focus on. That's the other thing. Syphilis is like it's in the backwaters. They're still using the VDRL and the RPR, and all the syphilologists are decrying that there's no better test for syphilis. Well, there's another outer surface protein called TRUMP, not Trump, TRUMP, treponemal rare outer membrane protein. You could quantify that and using the NIST method. And also there's other spirochetes. There's the endemic treponematoses, that you get in tropical countries, Pinta and Beagle and whatnot. And the testing for that is poor. And this method could be adapted to that, I believe. So it's just really it's frustrating to know that it is there and it's not being supported or developed clinically. Yeah, it would need more work, but hey, nobody wants.
And not even IGeneX is touching that?
No. I don't really know. I did run it by Jyotsna Shah, and I'm not sure why, but she didn't show any real enthusiasm for it. I mean, maybe they had their own methods that they were pursuing, and plus, I guess they have some kind of a culture now, right?
There's a new test coming out. It's going to be under a different umbrella company, but it's IGeneX developing it, and it's supposed to be an over-the-counter rapid test. We'll see.
I actually contacted by email the corresponding author for that NIST method, and I said to him, am I missing something here? Is the technology such that it's not practical? It's too expensive. It's not practical for commercial use, and also is this patented or something? That's why nobody wants a gun. He said, no, none of that's true. And he deliberately put it in the public domain. It's not patented. So it could be used. And nobody's using it.
Wow. I have 2 more questions. Would you treat a patient with tick-borne illness who only has high IgG? And I think you answered that before by saying you're making a clinical diagnosis as your patients come in, that the tests are secondary to your assessment.
Well, a high IgG is just corroboration that the patient's immune system has a memory of exposure. It doesn't, and there's a lot of dogma, okay, so IgM is recent, IgG is old, and if you've been treated and have IgG, some of the dogma is, well, you can't have the infection anymore.
Even if you haven't been treated, dogma is you don't need treatment. So it's a clinical diagnosis.
We can't hear you.
If the patient is exhibiting symptoms, can you hear me?
Come forward.
Oh,
Sorry.
can you hear me? Can you hear me?
Yes.
Yeah, so even if the patient has IgG and they haven't been treated, the dogma is to not treat them. They don't require it. That's not the way we see things in terms of tick-borne illnesses. So it's a clinical diagnosis. If the patient has an IgG exposure and they are exhibiting symptoms suggestive of that infection, then we treat them. And we treat them, we'll call it treating them empirically sometimes. We want to see if they still have that infection, if they need treatment. And so we want to see what the treatment, if it has an effect on their symptoms.
We have a question from medical doctor. Actually, it's a bit of frustration. He says, I've lost most of my trust in the system, the pharma, etc. How can we trust this new Lyme vaccine? And it's for me, and I'm getting away from the question here, that they might come up with a Lyme vaccine that's good against certain strains of Borrelia, but what about all the other tick-borne illnesses that are being carried? Will people get sloppy about protection?
Yeah, that's a good question. I mean, I think there's some researchers have tried to develop a vaccine that would cover a range of different tick-borne illnesses. But as far as the newer generation of Lyme vaccines, I mean, I think it remains to be seen how safe and effective they are.
The last question is about Buhner herb treatments and combining herbs and antibiotics. And you did touch on that in the beginning, that this person had heard that the two treatments together can be very potent.
I attended a symposium that he gave at it was in Massachusetts at what's that place up near 84 where 84 joins the Mass Pike?
At the Central Mass Lyme Foundation used to have.
It's at there's a restoration village. I forget Sturbridge. He gave us.
Oh, Sturbridge, yes.
He gave a symposium in Old Sturbridge Village, and this has got to be at least 15, 20 years ago. And I went
wow.
And he was great. He really knows his herbs, and he really knows tick-borne disease. I was very, very impressed by him. And I've read his book, and the book is very, very detailed. I mean, it tells you how to make your own herbs and concoctions if you want to do that. Yeah, I was very impressed with him. Again, I opted not to try to be an herbalist because it's really background. But yeah, if you really want good information, he wrote 3 books on Lyme and co-infections. They're very, very good. Of course, he passed away within the past year or so, unfortunately. Yeah, it was very good information.
So we're getting towards the end of our time here tonight, and I wondered if you'd like to offer up any closing thoughts on your practice and any supportive statements for our audience tonight.
Well, being ill with these born illnesses is challenging, it's difficult, but I somewhat jokingly say that we as practitioners and the patients, we have to be at least as determined, if not more so, than the spirochetes. And spirochetes are very determined, so we have to be more determined than they are. But you know what impresses me so much with so many of the patients is their determination to get well. They're so highly motivated to get well, and that's admirable.
Yeah, I mean, I just will add to that, I think the patients really need to, you know, when they're faced with this, they need to be able to understand that it is a journey that is going to take them some time to figure out what the best treatment is for them, and they have to be patient with themselves and just keep moving forward and finding, you know, what the best treatment option is. And there is some trial and error involved. You know, we don't know what somebody's going to respond to. You know, sometimes when I pick a treatment, they respond immediately right out of the gate. And it's great when that happens. That's, you know, that's wonderful. But sometimes they don't. And we don't give up. We have to try a different treatment or different combination of treatments. And so it takes some time to really figure out what's the best course of action for any one particular, you know, patient. So I would say they have to just, you know, kind of give themselves up to that journey and not give up.
Thank you so much for offering your time today. I know your practice is very busy. It was wonderful to have the opportunity to have a conversation with you and for our clients and viewers to ask these questions. And I hope that you both can come back again at some point. And hopefully we'll have more research, more good news in treatment options.